In every stage of life, a woman has the opportunity to make important decisions that can maximize her health and prolong her life. At the Washington Women's Center, we have the in-depth knowledge and breadth of experience in all facets of women's health care. We're committed to helping women get started on and to continue on the path to good health by helping them make healthy decisions along the way and by showing the way to achieving balance and wellness. This series of women's health programs is designed to offer women of all stages of life the information they need to live a healthy life.
So the idea is to do procedures with new little toys or new inventions that will take care of problems inside the body through a very small hole and a small conduit, and do this on an outpatient basis so that you can either come and leave the same day or basically with one overnight stay. And the procedures that we're going to talk about are all outpatient procedures. Okay, you're going to come in, get the stuff done, you're going to go home the same day, unless there's some other unforeseen circumstances that will prevent that. So that's pretty much what we do, high-tech plumbers. If you just remember that, that would be important as we explain the procedure itself. So PCS, pelvic congestion syndrome. What the name actually probably wasn't coined until fairly recently. I would say the last decade or so. Most people didn't even know what that was until the last decade. It's gained a lot more attention since then, but still a very underdiagnosed problem for women. In essence, it's varicose veins in the pelvis. So what happens is that, you know, we have veins all over the place. You know, they return blood to the heart, right? So in our body, we have the arteries and we have the veins. The arteries get blood from the heart into whatever organs that need them, and the veins return the blood from the organs to the heart, so it can be circulated again. The arteries have a thicker wall because it's a high-pressure system. It's very elastic. It's resistant to high-pressure system. And the veins typically are a low-pressure system and thinner walls, okay, which means that they can get stretched. And this is where the problem lies. And the veins also work on a valvular mechanism, meaning that the blood returns upwards, goes back to the heart. It doesn't, you know, you need to have something to prevent the blood from backflowing. So what happens is you have valves in the veins to prevent the blood from going backwards. So if these valves fail, that means the blood that goes up will come down back, you know, again. And the valves can either be faulty or they can be working properly, but the veins can be so big that the valves are not together, which means you have this wide open space for the blood to go back and forth. And that's where a lot of congestion problem happens, okay? So if the veins fail, the blood will pool. So you have leaky ceiling, water will pool on the floor, okay? And that's what happens in the pelvis. And these veins will get really engorged because of the blood pools in the pelvis, and it affects the organs in the pelvis, like the uterus, the ovaries, the tubes, the vulva. And after a while, it can get painful because there's just too much blood in there, okay? It's very gravity dependent because, you know, we're up most of the time, and the blood has to travel upwards against gravity. And so if the valves don't work, they're gonna go down, okay? So if this is a common thing, why is it that we miss the diagnosis so often? Well, if you go into the office, you'll be lying down, being examined. So say you got pelvic pain, and you have PCS, and you go into your doctor's office, and you're lying down, and all the blood basically now is able to sort of kind of return because you're horizontal, right? So it's no longer pulling. So when they're examining you, the symptoms and the signs aren't there, at least not as flagrant anyway. You know, it's not so obvious. And so a lot of times on physical exam, it's easy to miss the diagnosis, okay? So what are the symptoms? Very dull, achy, kind of pressure, pain in the pelvis, lower back, basically in the lower abdomen. It's typically worse after standing because the blood pools, right? So it's worse at the end of the day. It can be worse during and after intercourse, just because there's more blood going that direction during that event. During and after pregnancy, because we have more volume in general. When you're pregnant, you just, the body produces more volume of blood, and so you're more likely to get congestion. And it's worse during the menstrual periods. You get heavy periods. And then sometimes you get these gnarly looking varicose veins on the surface of the vulva. And you can actually see it, these blue veins that pop out, okay, or your vulva gets really congested. That means the blood it's really exceeding the capacity of the veins down there. You can have irritable bladder, and sometimes you even get vaginal discharge. Okay, so a variety of symptoms. How common is it? It's estimated that about a third of all women will experience chronic pelvic pain at some point during their lifetime. That's actually quite a bit. So up to 15% of women have varicose veins in the pelvis, but not always symptomatic. Sometimes it'll be just slightly varicose, but it's not enough to cause symptoms, okay? Or it's tolerable anyway. And usually happens between 20 and 50 years old, so childbearing age, okay? And if you take all comers who go to the physicians for chronic pelvic pain, about 15% of all gynae visits are actually because of pain. And in that, you have a third of them actually can be attributed to PCS. So it's actually quite a bit. So we're not really diagnosing this thing properly. And about 30% have PCS as the only cause of the pain. But certainly you have other people who have other things like fibroids, for example, causes very similar pain, okay? Adenomyomas, endometriosis, a variety of gynae's problems. But PCS is somewhat unusual in those who have not been pregnant. So there's a mechanical issue to this problem, right? Having that damage done to your veins during this childbearing process, having so much volume and damaging your veins. Risk factors: if you have more pregnancies, you have higher risk. Polycystic ovaries. If you have leg varicosities, like varicose veins in the legs, so what happens is all these veins are somewhat tied together. And if you have some risk factor for varicose veins in the legs, that means you have risk factors for the varicose veins in the pelvis as well, okay? And hormonal dysfunction. Estrogen has been proven to weaken the walls of the veins. So how do we diagnose this thing? I'm a radiologist in addition to being an interventional radiologist, so we do a lot of imaging, CT, MRI, ultrasound, X-rays, and things like that. One of the benefits of being an interventional radiologist is that we read our own imaging studies. We know exactly what to look for, and we know exactly what kind of study to get the quickest and the best diagnosis to get to the problem. And so some of the diagnostic tools that we use to diagnose this include venography, which is what we call the gold standard. It's probably the oldest imaging method to diagnose PCS, but most recently ultrasound, CT, and then MRI have been proven to be very useful, and I'll show you cases of that. This is an ultrasound image, okay? So what you're seeing, all this tangle of snake-like vessels are the varicose veins. The blue and the red. The blue and the red are basically the way the machine depicts blood going forward and to and fro, okay? Coming and then going. And so they have different colors. And it can be either way. I mean, it could be vein, artery, vein, depending on how we set the machine. But at least you know that there's all this tangle of vessels with blood going all over the place. So this is a typical picture for a group of very varicose veins. There's another one here in the pelvis. Okay, you see, you shouldn't see this many arteries and veins in the pelvis with all these huge, tortuous-looking, gnarly-looking arteries and veins in there, mostly veins. That's what you see. Okay, now this is another patient. So typically, when I see these, it's rare that I see them on an outpatient basis. I typically see them coming through the ER with left lower quadrant pain, meaning left side lower abdomen pain or right lower abdomen pain. And they come in because people think they have diverticulitis or appendicitis because the pain mimics that, it resembles all the other problems. And so this one came in, has left lower quadrant pain for weeks, young woman. And you can see this is a CT, a CAT scan slice. So this is what we call axial slice. We're slicing this way, okay, like a bread loaf, okay. This is in the mid-abdomen level about right here. 2 kidneys, left and right. Tip of the liver here. And this is this bright spot here is the aorta, the big artery that runs from the heart down to our legs, okay? And then you see this thing here? That shouldn't be there. That's another vessel. That's a big ovarian vein. That's varicose. Okay, it's almost the size of the aorta. That's big. Okay, you go down a little bit lower, it splits into 2. And as you get lower, now we're into the pelvis, right? This is where our pelvic bones are, the hips right here. Okay, the big bones there by our buttocks. Okay, and this is our spine here. And so now it splits into like even more of them. And you get down all the way to the bottom here. This is the uterus right here. You can see it's kind of like, it's got a lot of little tiny things in there, little vessels in there. It's more than usual. But this group of vessels here, those are the varicose veins. This is a pelvic congestion syndrome patient who doesn't even know. Okay, so we get the CAT scan to rule out appendicitis, and this is what I see, or diverticulitis, and this is how I catch them. And so she's had this pain for a long time, but really never got diagnosed because whenever she goes to the physician's office, the pain wasn't quite there. And it's difficult to diagnose something like this without some sort of an imaging tool. Okay. See these big ones here? They go right into the uterus, right? So actually it's trying to return blood, but everything's backing down into the uterus. So this is the same patient, but you can see it. This is now looking at you from the front. We're slicing sideways like this, coronal we call it, okay? So you can see the kidney here. Here's the left ovarian vein. It's the same case, okay? You can see those 2 veins coming down. Okay, you come down here. See this big one here going in there? This tangle of, pretty bad, huh? This is an MRI study. Okay, you look at, this is the coronal again. You're looking at it, this way. And this is an axial slicing this way, okay? So you see this is the kidney. These are the kidneys. Here's the aorta, splits into 2, goes into your legs, okay? This is the left ovarian vein. That's big. You shouldn't see it at all. But you can see it coming down here, all these big ones hopping across to the other side and even over to going up into the right side. That's a really bad one. And if you look at it cross-section, you see all these big tubes here. Those are the varicose veins, okay? And that's what you can imagine how much, when all the blood pools down there, how much pain that can cause. This is a venogram. Old-fashioned venogram. And this is the tube, the catheter that we use to inject dye. We get it into the ovarian vein through a little tiny puncture hole in the groin here. We go all the way up, hop over, come down, all inside the vein, okay, without using any knives. And we get this tube in here, we inject dye. And you see this just a tangle of really dilated, big veins. And this is what's causing the pain. These are the varicose veins. And then hops over to the other side and goes up. You see how bad it can look, how big these can be? This is in here. Okay, so this is about 20 times the size as it used to be because the valves fail. Okay, so how do we treat this? Now, it used to be that they would do surgery. So they would go in there, they would try to tie off the veins surgically, so obviously you got to open you up and find the veins and try to tie it off, and then they got to tie off multiple areas. Sometimes they'll take out the ovaries, they'll take out the uterus, and sometimes can be pretty extensive, and then it still may not work, okay? Because if we don't get all of it, then it will come back. So now in the last 10 years or so, we've been doing something called embolization, and what that is basically plugging up the veins. So embolization is general word we use for a lot of things. In interventional radiology, if something is leaking, again, like plumbing, so pipe leaks, we plug it up. If a pipe is clogged up, we open it up, okay? So the plugging of the pipe, of the veins or the arteries or anything is called embolization. That's what that word means, okay? You put something in the vessel to stop it. And you can use all kinds of stuff to stop it. One of them is coils, okay? These are little coils. Now, they look big to you, but they're actually tiny. I mean, they're probably like this big, tip of the pencil. Okay, it's not that big. And they come in various sizes, and they come in various shapes. These are helical or tornado coiled, helical coiled, and these are delivered through these catheters, these little tiny tubes, which are the size of, again, the tip of the pencil. So we squeeze these things. Once we get the tube to where we want to go, to the tip of the vein, we squeeze these coils, which are, when you stretch, kind of stretch them out, they're straight. And you push them through the coil, into the tube, into the catheter, and then you tap it out. And then when it comes out, it forms a coil shape and it plugs up the vein. And all these fibers in here basically causes an immediate reaction, and the blood clots up, forms a clot. And the vein, the walls kind of spasm down, and it causes inflammation, and basically scars down, and the vein shuts down. And it can be done in any vessel, obviously, but in this context, we use it to shut down the vein, okay? And sometimes we mix it with some chemical agents, a little bit of alcohol sclerosing agent or glue. Not the super glue you buy in Home Depot, but medical glue, yeah, the different kind of glue. But you put a little glue in there, and you put it in there, and it just glues everything shut, okay? So this is one case. Here's that big vein, the ovarian vein coming down here. You see all these, big veins. And actually, if you look at this one actually connects all the way down into the leg. And this person has varicose veins in the leg. So the two are connected because it's, it's one big system. And so with pelvic congestion syndrome, sometimes you find concurrent varicose veins in the legs, or vice versa. And so what we do is we go up, over, get into the veins, come down here, and we put these, you see these coils in here? We shut it down by putting coils in there, and here's a coil being delivered, okay? So you push that out into the vein, and it forms this shape and plugs it up. Here's another case. Big vein coming down here, crossing over to the other side. You deposit a few coils like that. They don't have to look nice. I mean, I know they look kind of messed up, but it's okay. As long as they plug things up, we're happy with it. So, embolization, a minimally invasive outpatient procedure. You come in the morning, you get into we do this in a angio suite where there's a big C-arm machine that has X-ray, and you're on the table, and as I step on the pedal, I can see the inside of you in real time, basically. I inject dye, and the dye gets seen, like you saw, gets mapped out, and this is all done in real time. I'm watching it as I'm doing this. Okay, it's kind of on TV. There'll be a monitor in front of me, and I'm watching this, and I'm watching the monitor, and I'm doing the procedure at the same time. So there's no opening of things. You do it. I'm watching the monitor while I'm doing things inside your body. Okay, so it's a minimally invasive procedure. When we're done, we send you to a unit to be monitored for a few hours, and then you go home with pain medication and things like that. So it's an outpatient procedure. It's pretty safe, no incisions, fairly rapid recovery. It depends on people, and sometimes if it's really extensive, it may take more days to recover from some of the post-op symptoms. But a lot of times, people are able to get back to work within days. Okay. Technically successful in up to 100% of the cases. The veins are not that hard to get into because they're big, so technically it's very easy to accomplish. Okay. And about 85 to 95% of women report symptomatic improvement with embolization. Okay, so that's actually a fairly high success rate clinically. Sometimes in the worst cases, it will take a few weeks to really, have the symptoms go away completely. But there's a gradual improvement typically. Okay, and the milder cases like the CAT scans that I showed you, if you embolize those, symptoms will go away usually within a week, okay? And sometimes if it's really bad, so if we plug up the big veins, and then the small veins are still there, and what the body tries to do is it'll recruit, tries to grab other smaller veins and try to find feeders from other branches. That's called parasitizing other branches, okay? And then you might have to go back in there. If that happens, then you have to go back in there and cut off those smaller branches, just with more embolization. Again, you know, another outpatient, but that's rare, really rare. So that's the essence of PCS. All right, I'm going to move on to varicose veins in the legs. This is what varicose veins look like, and this is what we hope what it'll look like after we do something with it, okay? So superficial venous insufficiency. Superficial varicose veins, okay. They're in the legs, you have a superficial system, and you have a deep system. The veins that are mostly varicose, the ones that you see, are the superficial system. Usually those are the ones that are more, that are closer to the skin, okay, so they pop up and you can see them. The deep system usually sits in the middle, and it's among the muscles, and the bulk of the work to return blood back into your heart is done by the deep system. Because every time you walk, you squeeze your muscle. Anytime that the muscle works, it basically squeezes the blood goes back out, okay? And it goes mostly through the deep system with help in the superficial system. The two systems can be connected by perforators, okay? And within each system, you have veins called communicators, okay? It'll become important why when we talk about how we do this thing. So the superficial veins, you hear greater saphenous vein. That's the vein that typically is harvested when you have a CABG, when you have a heart bypass. They'll strip that vein to use in the heart, okay? And then in the deep system, we call them popliteal, femoral, and tibial veins. And when you hear blood clots in the veins, you hear DVTs, okay? So you get blood clots in the veins, and family members had it before. That happens in the deep system typically, okay? And if they form clots in the deep system, and the problem with that, with the DVT, is that those clots can break off. They can go upstream through the big pipe called IVC, back into the heart and get pumped out into your lungs. That's called PE, pulmonary embolism. That can kill you, okay? So the DVT, PE thing. So that happens mostly in the deep system, okay? But the two are related. So when we do the varicose veins, we gotta make sure the deep system is open. Otherwise, if it's shut down and we shut this down, then the blood goes nowhere, then you're in trouble. Okay, so if you look at this thing, what causes the varicose veins? Okay, so blood typically goes up, goes through the valves, and then the valves should basically form this shape, okay, and then the blood can come back up, right? So like this, flops up, and then forms this. So then when the blood comes down, it shuts down, doesn't do anything, right? Okay, so that's a competent vein. When it's incompetent is when the valves flop, and the blood goes up, comes right back down, okay? And you look at this leg, this is the greater saphenous vein coming down here. It gives off little branches here and there, but these are the branches that if you get blood backing up down this way, then all this blood will back up into these branches. And they're very superficial, and those are the ugly looking blue veins that pop up under your skin, okay? And this is the deep system, okay? Here's the up in the groin here, it's called the common femoral vein. Now the saphenous vein, the greater saphenous vein is here, this thing. Here's the lesser saphenous vein. This is the deep system, okay? So most of the time, the varicose veins that we see are in this area, this greater saphenous vein, and lesser here. And the deep system are the ones that return the blood, okay, that can form clots. Okay, so this is the diagram where this is a normal vein, okay, the vein goes up and then can't come down because the valves are shut, right? They're like this, so you can't go down anymore. When the valves fail, say you had clots in there before, for whatever reason, and the valves get damaged, they get scarred down, they're no longer functional, then the blood can freely go up and down, up and down, up and down. And that's when you have varicose veins. And then eventually what will happen is that the veins get stretched. And they get really big because the blood pools in there, and then, basically, then the vein's no good anymore. And sometimes you have so much blood volume, like in pregnancy, it stretches the veins without damaging the valves first. That's a problem too, because then the valves are no longer useful because you have this central channel that can sort of kind of let the blood go back and forth, okay? So the first thing we do is really just take a look at your veins. And the important thing about this is we use ultrasound to diagnose the varicose veins. Ultrasound is used to tell us where the veins are, how big they are they refluxing, meaning is the blood going up and down, or is the vein competent? The blood just goes up and doesn't come down, okay? So ultrasound is very important. And also to map out where these varicose veins are. So when we do ultrasound, we'll look at it all the way up and down, and then we actually draw on the skin all these branches that pop out, and then figure out whether or not there's actually an incompetent perforator between the deep and the superficial system. So sometimes the superficial system is okay, but what happens is there's this branch that connects the deep system to the superficial system, right? So the blood comes up the deep, and this branch is not competent. It's got valvular problems. The blood shunts over, goes up into the superficial system. With time, there's so much blood flow going this way that this superficial vein can no longer handle it. And then it becomes big and the blood goes down, okay? So incompetent perforators are frequently missed. And so what happens is you can shut down the superficial system, but you still have this branch there, and it continues to shunt blood, and your procedure, your vein would just open up again. The procedure will fail. That's one of the most common things that people miss, okay? Does that make sense? Okay. So this is a varicose vein, and that's one of those. You look at it here. Here's what I was telling you, the greater saphenous vein. It dumps into the deep system up by your groin area, okay? And so you see this junction here, that's very important. When we treat, we start like about right here. And we start to shut down the vein from here, okay? And this is what I was telling you about a perforator, okay? So it goes from the deep system. There's a branch that goes over and shunts into, and goes into this superficial system. So this blood keeps going this way, this way, this way, instead of going up. And eventually, this vein here is going to have issues. It's bigger, you see already? Okay, it's going to get bigger and bigger, and you can't handle the volume, and it will fail. And so basically what you can do is, I can shut this down, but if I haven't shut this down, it'll continue to do this. It'll open back up again, okay? So EVLT, the way to treat these veins used to be stripping, okay? And now we have a minimally invasive, there's a catchphrase again, minimally invasive procedure to shut down these veins. And the way we do that is by laser or by radiofrequency ablation. Okay, two different things. It accomplishes the same thing, it just uses different energies. One is laser and heats up the vein. Radiofrequency ablation uses radiofrequency, also heats up the vein. Either one is okay. EVLT, which we do, is the laser part, okay? And it's quicker. I think it's, personally, I think it's a little safer. There's less bruising than the RF, the radiofrequency. So it's probably about a 45-minute, 1-hour procedure, depending on how extensive your varicose veins are. And you use the local anesthesia. You basically use lidocaine. You numb up the vein all the way up and down where you're going to do this. And you put the laser in there, and I'll show you how it's done. And basically, at the end of the procedure, we wrap your leg up. We make you walk around a little bit, okay? And we send you home. And you just wear your pressure stocking, your pantyhose. Eventually, after a week or so, the vein will scar down, okay? And we'll have you come back. We'll take a look at it with ultrasound again, make sure it's still shut, it's still, scarred down. And the blood would then get shunted, get diverted back into the deep system where it's competent, and all these varicose veins will go away. Okay. So, how common are these? Well, mostly women, but you'd be amazed that quite a bit of men suffer from this as well. Probably because there's long hours of standing. Again, blood pools down, and that causes problems there. Okay, so 100 to 150 million people. A lot of people don't get treated because sometimes it's just ugly looking, but it's not painful, and so people live with it, especially men. And by the time that it gets painful, it's pretty bad. It can cause ulcers. Did you know that these veins, these varicose veins, when you have these branches that come out to the skin, after a long time, this pressure actually causes venous ulcers. Like we think about ulcers being caused by artery problems, but actually veins can cause venous ulcers, and that tends to be missed as well. You get these hyperpigmented, like dark skin areas after a long time, and then gradually the skin will break down because there's so much pressure there, and you get an ulcer. Difficult to heal, very difficult to heal. If you don't take away the cause of the problem, which is the vein, then it won't heal at all. And so obesity, pregnancy, again, age, prolonged standing, basically are some of the additional risk factors that add to this, okay? So this is the traditional surgical treatment. You strip it, you get in there, you cut the vein, you wrap it around, you tie it up, you get something inside there, you tie the top end, and you pull it down. And basically you end up inverting the vein and you strip it out. You just basically rip it out, okay? Surgically, you rip it out of there. So no vein there, no varicose vein. But it's pretty invasive, it takes a few days, weeks to recover sometimes. It can be very painful. You're left with incisions, right? Scars, possibly. So it's few people do surgical stripping anymore, okay? Most people end up with minimally invasive ways to treat it because it's so simple. The problem with that is, you have to use general anesthesia, which carries with its, its own risks. Got to be in the OR. You have pain after the stripping, understandably, bruising in the area, and 2 to 4 weeks for recovery, which is quite a bit. It's downtime from work. Sometimes you have recurrence. If you don't strip it right, like I said, if you miss some of these areas and branches that feed into, if you don't strip it at the right level, it'll just come back again, okay? So what's this EVLT thing? So basically, as you can see, you take the how does it play again? This is the machine. This is the laser machine. It's actually not very big. It's about like this. It just generates energy, that's all, into a laser fiber, okay? So we get the fiber in here, all the way through, threaded from the vein, typically below the knee, okay? We numb you up, put a little tiny needle in there. Through the needle, we put the wire up there, and then we get a laser fiber all the way into the vein, up here to where I said was a junction, okay? And you activate the laser, and before you do that, you put a lot of anesthetic. You inject it around the vein, and so you compress the vein right around the laser fiber, okay? And this way the laser fiber is touching the vein wall. And then you turn on the laser, it heats up, it boils, really actually boils the area, and it scars down the vein like this. And you slowly pull it back. So you put it up there, and then you activate it, and you slowly pull it back, and the vein gets sealed shut. And you pull it out, and that's the end of it. That's the end of the procedure, okay? Sounds easy, huh? Basically, if you look at the vein itself, okay, the idea is that if you can have wall contact with the laser fiber, as the laser is passed through that area, the catheter or the laser can generate enough heat to scar down the vein. But if you don't have that good contact, you got to get that good contact of that vein wall to the thing. So you got to inject anesthesia around it. So that's very important, to be able to get some anesthesia. That's the part where a lot of people fail to do. Inexperienced people doesn't get the contact to the laser fiber, and that's why you have sometimes failure of the procedure, okay? So we use ultrasound. We get the needle in there, and then we start to inject anesthesia around it. Here you see a laser fiber inside the vein. And we inject all this, looking at it now, this is again cross-section. Here's a laser fiber inside. You inject enough lidocaine or anesthesia around it, so it wraps around, the vein just shuts down, wraps around the laser fiber, and then you start to pull it back. And that seals off the vein, okay? And then afterwards, you dress the leg with compression bandage, and then wear class 2 stocking. You take a 20-minute walk around the nice facility, and then you basically go home and resume normal activities. Then we have you come back in a week or so, and you can take some pain pills at home if it hurts. Usually Tylenol, Motrin will be able to do the job. And we check you with ultrasound in a week or so, and if it's still shut at that point, typically it won't reopen again unless you've neglected a perforator or some other branch. Okay. Follow-up care. Like I said, we do a ultrasound, and then again we check it again at 3 and 6 months, just to make sure that there's no other issues that pop up to recanalize the vein. And most of the time when it's, we don't really do the year after anymore unless you have new varicose veins that pop up. Then we have to see where it's coming from. And then when we're done with the laser part, that's when we attack the smaller veins, like the spider veins. We do some of the telangiectasias, which are kind of these tiny little reticular things. And so the things to do, the ancillary treatments are sclerotherapy, where you take a tiny needle and inject basically a sclerosant. So you just take a magnifying glass, you look at the spider vein, you take a little needle, inject it, and basically you're scarring down the little veins, the spider veins, okay? And phlebectomies, sometimes if you take out the big trunk, the greater saphenous vein, and you have all these little branches that are really ugly looking, right? They're filled with blood. Now that blood is going to stay there unless it has a way to drain. So sometimes what we do is we do a phlebectomy. So we go in there, we make a little tiny stab, like probably, the tip of the pencil again, and right next to that vein that's bulging out. And then we take a little hook, we go inside, we hook the vein, and then we just slowly twist it and just grab that branch and it comes out. And so we remove the branches, but not the trunk, okay? And that's basically to avoid trapping of blood inside those branches, which then can become clots. And that's what we call superficial thrombophlebitis. I don't know if you heard that term before, but that can be painful, okay? So that's the phlebectomy, okay? So what can you expect? You might get some mild bruising right along the vein pathway. Sometimes people feel like a kind of a pressure, tightening sensation. Some tenderness along the vein, usually only for a day or two, no more than that, and usually taken care of by Tylenol and Motrin, okay? Studies, well, lots of studies have been done. Dr. Min, Robert Min, is one of the inventors of this thing. He's at Cornell in New York, and he's done a lot of studies on this. He's probably done most cases of all people in the U.S., I think. And in his initial study, 98% success, closed at 3 to 42 months. 223 limbs follow for these 2 years, and they continue to be occluded. Okay, so that's pretty good data. This is one of his patients. Really ugly looking, really ugly looking veins in the calf here. I suspect this one has small saphenous or higher up, some greater saphenous truncal reflux. And all these little branches here are because the main trunk is not working, so basically all the blood pulls into the branches. Okay, so if you take away the reflux, the problem, these branches hopefully will no longer be big because the blood won't reflux there anymore. It'll get shunted, it'll get diverted into the deep system, okay? So another study, 400, almost 500 veins treated in 423 patients, 98% success rate, and more than 93% are still closed over 2 years. Now that's pretty good. I mean, for a lot of procedures, that's really a really high success rate. A lot of procedures fail as time goes along, but in 2 years, you still have this kind of a success rate. That's pretty good. And the thing is that everything is done under local anesthesia. Okay, so you walk in and you walk out. Okay, we'll go over to, so the advantage of this over surgery: safe. It's in office. It's quick. It's non-scarring. Basically, it's just a needle puncture site. No incisions. Okay, you can go back to your work, basically with very little downtime. And the cost actually is a lot lower compared to surgery. So most insurance companies will pay for this. If you have symptoms and we pre-authorize it through your insurance company, we document that by ultrasound that you have varicose veins, that there's reflux, that it's causing you symptoms, most of the time, almost all of the time, they will approve it, okay, in most insurance companies. And the cost really is probably, I think in this area, it's around it's 2,000 to somewhere between 2,000 to 3,000, which is probably a quarter of, or maybe less of what surgery would be. Okay, and even if the insurance companies doesn't approve it, a lot of people work out plans, payment plans, so that this can be done. Different centers do it differently, but if we can document with ultrasound that you have the problem, that it's refluxing, and you have symptoms, typically it's not an issue, okay? Okay, so this is a mild case. You see a few veins down here, and you treat the GSV, you treat the greater saphenous and the lesser saphenous vein, and that goes away. So this is, obviously a younger patient and would be ideal, be pretty quick and easy to do. And not all cases are like that. This is another one in the front. You can have it in the back or the front. You can have it in the knee. Some of these are very big. Look at these. They're huge. And some of these may require additional therapy, like the phlebectomy. And after you treat the truncal, you may have to take out a few branches. But the main problem is that you got to take away the truncal reflux, because that's what's feeding all these little branches. Okay. Again, some of these are very ugly looking. These are smaller branches. Look at that. These are really long-standing problems, and with this, you can't just take out the truncal reflux and let this sit, because all the blood will pool in here, and they'll become like cords, like hard cords. And you got to really actually take out some of these, not strip it, but phlebectomize it. Like you hook it out at the same time that you do the laser, so that they can't trap blood in there. Okay. Again, let's see here. Yeah, some of these are like that. Same thing. This is in the back. So this is actually maybe one that has a different vein, a vein of Giacometti or something like that. This is, you see the pathway is a little bit different. Goes up behind and wraps around the side. Now the women will have some of these varicose veins that go all the way up and actually go all the way up to the vulva, and they dump into the pelvis. And they have concurrent varicose veins, not just in the legs, but also in the vulvar regions. And you actually have to go hunting all the way up there and take out the source of the reflux. It may not just be in the greater saphenous vein. It may be feeding from some of what we call pudendal branches, which is deeper. Okay, and that becomes more complex. And why does it happen? Because you just sort of kind of let it go for too long, and then eventually the system gets all backed up. Okay, and I think that's it. Okay.
So
all right. Thank you for coming. Appreciate it.